Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Welcome to another VivaCast episode for GasGasGas. This episode is Tom answering questions on approaching a laparotomy in an oncology patient. As ever, it's really important to have some structure when answering these questions so it doesn't look like you're jumping around between ideas that are coming to your mind during your 15 minutes. We let Tom answer this question and then we debrief afterwards and explore how to improve structure. I've put on the show notes a structure about how to approach these questions so that you come across looking slick. If you can make an examiner think that you do indeed know what you're on about, that is half the battle. Anyhow, with avoiding too much preamble waffle, we're going to pearl straight into this and we'll hear what Tom has to say. This is your clinical viva, 15 minutes or so. You've been asked to see a patient on the oncology ward who's unfortunately got a bowel perforation with bowel obstruction. The surgeons have listed them for a laparotomy. Part of their handover tells you that their urine output has been 15 mils an hour since she was catheterised 6 hours ago before her scan. Her heart rate is 124. Her blood pressure is 103/40. And the surgeons are going to give her a bit of fluid. And naturally in the exam you'd have 5 minutes to think about this. Would you like me to read that back to you?
No, I think I've got the details.
So could you summarise that for me, and what are your immediate concerns?
So we have a patient who's got known bowel obstruction with perforation, who has signs of hypovolemia and possible that they're beginning to go into shock as well, which either could be sepsis driven or they could be having vast third spacing. The important thing here is that we have a sick patient. He needs to go to surgery urgently. So on attending this patient, so did you ask for an anaesthetic plan or did you ask my approach initially? I just want to clarify the question. So
I was just looking for you to summarise and tell me what your initial concerns were. So what is your approach going to be?
As I said, we have a sick patient, poor urine output, low blood pressure, bowel perforation and known obstruction on an oncology ward who potentially is comorbid and has a potentially chronic and incurable illness. My initial approach is going to be an A to E approach. So it's a sick patient. I want to go thoroughly through A to E systems and make sure there's nothing that we're missing that's making this patient more unwell. And I'm going to have focused on two things in particular. One is how am I going to optimise this patient should they come for surgery? And it's certainly going to include some fluid resuscitation, probably some further tests including VBG. Find out what their lactate's doing, what their electrolytes are doing, lab bloods as well to look at their electrolytes, FBC to see if there's any evidence of bleeding or chronic anemia due to chemotherapy, things like that. But the other thing that I'm going to have to think carefully about as well is whether surgery is suitable for the patient. So that's going to depend significantly on the clinical background. So after doing my initial A to E, I'm going to try and find out a little bit more about the patient's functional status.
Okay, just holding you there for a second.
Yeah.
You mentioned an A to E assessment.
Yeah.
What would you actually like to know?
I want to know, what do they look like from the end of the bed, first of all? Does this patient look like they're peri-arrest or do they just look like they're a little bit dehydrated? I want to know what their respiratory pattern's like. Have they got massive tidal volumes that indicate significant level of acidemia?
Yeah. So they do.
Are they on any oxygen?
So they are on a bit of oxygen, 2 litres via nasal specs, and their respiratory rate is 25-30.
Okay. Further into my assessment, I'm going to be auscultating the lungs as well. They may have concurrent pneumonia. You know, they potentially, I don't know the details of patient treatment. They could have had procedures that predispose them to pneumothorax or something like that if they've had drains and things inserted. I'm going to want an X-ray as well for this patient if they're needing oxygen. Moving on to circulation, I already know they're not producing any urine, but I want to know, are they cooled peripherally or are they vasodilated and hyperdynamic in their circulation? Are their mucous membranes dry? Are they passing large amounts of liquid? I was going to say from their bowel, but actually we know they're in obstruction already. But I might look at their scans as well and look if there's evidence of large volumes of fluid within the bowel, which might be contributing to hypovolemia.
Yes.
And resulting in their poor urine output. I want to know, are they awake and alert, or are they drowsy, or are they slipping into unconsciousness? All of these things are going to help me judge how sick they are and what needs to happen next.
So, from a cardiovascular standpoint, I'll tell you that they are cool peripherally, their central capillary refill time is 4 seconds, and that they look quite pale. She's conscious to voice but dozes off mid-conversation. Her blood sugar is okay, and her mucous membranes are dry.
Okay. And does she have any history of cardiac disease or recent chemotherapy that could have caused new cardiac disease?
Yes, it would be important to identify what her past medical history would be and what her current admission looks like. Are there any other parts of the history that you would like to identify?
So after my A2E assessment, I want to know their full medical history. I want to know their surgical and anaesthetic history. I want to know their dental history as relevant to airway assessment. I want to perform an airway assessment. I want to know any allergies. I want to know whether they're vomiting. Is this person already got an NG tube in that's draining well, or are they actively vomiting? And those are things that strike me immediately. Alcohol use and smoking are going to be important as well to know about.
Mm-hmm. And you mentioned a few investigations there. Could you just summarise those for me?
Yes. So I want an FBC to know whether this patient's anemic, whether they're iron deficient, whether they're going to need, highly likely to need blood. I want to see UNEs in their bowel obstruction. They may well have deranged electrolytes, and I want to see how bad their renal function may be on biochemically already. I want a VBG, which is going to tell me about their acid-base status, whether their lactate's raised. It may suggest to me if there's any possibility of ischemic bowel as well, which may have implications for anaesthetic and surgery, and could prompt a further discussion with the surgical team, perhaps the radiologist, if I had suspicions there. And I want to make sure I've got an ECG, and preferably a baseline ECG from previously as well. Given that they're going to be undergoing major surgery as well, when we send those bloods, we're also going to cross-match some blood as well.
Okay, you mentioned that you would like an ECG. I'll tell you that this patient is in AF with a heart rate of 130. How are you going to manage this?
So we've already got good reason to believe this patient is hypovolemic. So initially I'm going to fluid resuscitate them as appropriate to their medical history and their weight. This may be enough to bring their rate down to something much more satisfactory and may make them more stable on induction. I'm going to look at their electrolytes and place potassium to at least above 4 if I have time to do so. I'm going to, depending on my judgment of their clinical state and whether they're responding to fluid resuscitation, I'd consider giving them magnesium slowly as well, avoiding hypotension as possible. I'd also want to know if they're known AF, whether they're on anticoagulant drugs, which can have implications for surgery, and they may need reversal agents if they are on any anticoagulants. And I want to know if they're known AF, are they on any medications for rate control, and when they've had them, and whether they might have absorbed them, the time course relating to their current illness.
Okay, so all in all, it sounds like quite a complicated patient. How might you go about stratifying their risk?
So the National Emergency Laparotomy Audit Score, the NELA score, will help us stratify this patient's risk. So this will take into account multiple data points about this patient, like blood pressure, blood results, and the proposed procedure and pathology. That will give us a 30-day risk of mortality, anything over 5% considered being high risk, and that will help inform our planning for the perioperative period, as well as inform discussions with the patient about how and whether to proceed.
And how would you approach proceeding with anaesthesia in this patient?
So this is a sick patient undergoing a major procedure. I'm going to make sure that I have a consultant present in order to anaesthetise this patient. Partly my judgment will be based on how well they respond to resuscitation, but I would consider arterial line monitoring for induction, and I would certainly put an arterial line post-induction even if they'd responded well to resuscitation. I'd want to consider central venous access. If they were deteriorating despite resuscitation, I'd probably do that pre-induction as well in anticipation of needing to give them vasopressor support. I want to minimise the chance of hypotension on induction in this hypovolemic patient, so I would certainly consider use of agents like ketamine rather than propofol in order to maintain their blood pressure, but that would be judged again based on their medical history to some extent. If they had severe ischemic heart disease, I may consider an alternative approach with high-dose opiates and lower-dose propofol, for instance. They're going to need a rapid sequence induction because they're in bowel obstruction. They're going to need their stomach emptying prior to induction as well, which can be done via suction with a nasogastric tube in situ, preferably done before they come upstairs to theatre so that they're not gagging and vomiting in the anaesthetic room.
Who else are you going to talk to about this patient?
So this patient, without running a NELA score, is likely to be in a high-risk category and is going to need a bed at least on HDU post-operatively, and actually if they are needing significant vasopressor support intraoperatively, they may well go as level 3 to intensive care unit. So I need to discuss with the intensive care unit about where they go post-operatively, as well as discussion with the intensive care unit and the surgical team about those things. We also need to speak to the patient and their family about the procedure itself. Again, I don't have all the information, but this patient is likely to be high risk, and the patient themselves and the family need to understand that before they go for their procedure. The risk of mortality is likely to be high. We need to discuss whether or not we're going to attempt to resuscitate them in the event of a cardiac arrest, and in what situations we might do that intraoperatively versus on the intensive care unit. Post-operatively, we may have slightly different approaches, but all of that needs to be discussed and as clear as possible to the patient and their family prior to going for the operation.
I don't know how long that's been, Tom.
You weren't timing. It felt long.
It felt like a while, didn't it?
Was there anything else that you wanted to cover?
No, I think that's pretty much everything. I suppose, yeah, let's call it there. So, immediate feedback, but your reflection first. Is that something you're used to managing?
Yeah, it felt fairly familiar. I think because it felt familiar, I launched off a bit too quickly in some things, so it could have perhaps been better structured. A to E stuff was probably okay, but after that first run through, I think after that things were in a slightly higgledy-piggledy order. So even I suppose when you're asking about how to anaesthetise the patient, I could have talked about that in terms of A to E, or I could have talked about that in terms of preoperative, intraoperative, and postoperative, and that might have taken me naturally onto some of the points that you had to ask about later on. So yeah, it could have been more structured.
Yeah, so I think that would be what I would talk about as well, is that it's very easy to start just having a natural conversation about how you would do this. But in an exam, they almost want you to be a little bit succinct and robotic. Maybe in part because it's easier for them to mark you, but also if it's 3 a.m. and you're doing this, you need something to fall back on that you know you will manage so that you don't miss things. So I think framing it in your mind as pre, intra, post, framing the pre as initial information gathering from the surgeon, an A, B, C, D, E, where you actually tell me a little bit about what you're going to do in it, because anyone can say A, B, C, D, E, but what does that really mean? And then a history and any other examination points, and then investigation, and then appropriate conversations with all parties. Doing it in that stepwise order stops you from jumping around, because it was a bit like, oh, I'm going to do this, and oh, I'm going to check that. And whilst that's kind of how your brain does think most of the time,
it's hard to follow as an examiner, and it just makes you seem less on it.
And you've just got to be brutal about it, I suppose. And then when you're shifting to how would I anaesthetise this patient, points for certainly your consultant has to be there. A competent ODP.
Oh yeah, I didn't think of that yet.
Yeah. Are you going to resuscitate this patient on the ward or in theatre? I.e., you're going to whisk him away because you just can't get anything done on the ward. You mentioned RSI, so that means suction, a tipping trolley, pre-oxygenation.
Oh yeah, so you have to talk about those things explicitly.
I would, just very quickly, just because then it just shows that clearly you're sharp and you've got a plan. Bam!
But you're right. It is even not for exams. It's good to have an explicit system for thinking about these things, because at 3 a.m. you can forget to make sure the patient's on a trolley and then have brown trousers when they start to aspirate.
Yeah, especially in a patient with bowel obstruction and perforation. Like, that's probably the only time for me where I think that definitely doing like a proper RSI is a smart move. Because if they're barfing up poo, you kind of want to be careful. Then where did we go? We talked about managing their AF, and I think you did that quite clearly, and also mentioned the troublemaker here is that you can't give them drugs that slow their heart rate down or are negatively chronoinotropic if they're sick as a parrot. It's a bit of a pickle. As well as the bolus of magnesium tanking their already quite crap blood pressure. So he picked up on that nuance. That was ace. And I could not remember what NELA was as an acronym, Tom, and that made you sound really slick. So
I only just remembered in time. Part of my brain was going, why have you started to say it when you don't know what the last word is?
Yeah, but it just rolled off your tongue, actually, so nice, neat and tidy. And I suppose the stratify risk angle, you could probably elect to then bring into the conversation disposition of the patient, i.e. would they be for intensive care? You could use the buzzword of having an MDT discussion with the surgeon, the intensive care consultant, and the anaesthetic consultant, plus minus identifying what the patient and the family's values are to make a decision about going ahead or not. Because we could have actually spun this that I could tell you she had terminal cancer and she actually was in her final throes of life, and therefore was it appropriate or not?
And in an exam, I think I'm guessing that you're right, that saying you're going to have an MDT discussion and involve the patient and family at an appropriate stage is the best you can do, because in reality, in bowel obstruction, there's very few cases where you're going to do nothing just because of the distress it's going to cause the patient. But no assumptions, it's an MDT thing, isn't it?
Yeah. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.